Before I speak, sometimes we always share our disclosures. I have a large disclosure. I'm not a data scientist, although we might be able to argue that in the midst of my presentation. But I'm a doctor. I work at the bedside. I'm never in a lab. I'm hardly in my office. I literally stand at bedsides in the cardiac ICU just a few blocks down. So what I'd like to do today, maybe you can even put your brains on hold a little bit, because I'm going to go from single cell, like our brilliant first and second speaker, to the entire child, and how we treat children and how data science actually affects our decision making at the bedside. So like I said, this is probably be a little bit lighter than what you've heard earlier since 1 o'clock, but like I said, please join me right at the bedside, a couple blocks down. So just want to introduce you to what I do, what we do at Texas Children's Hospital, where we do it, and who we do it for. So first, Texas Children's Hospital, many of you Houstonians know, is probably the biggest pediatric subspecialty hospital in the country. We rank 4th for all around pediatric subspecialties, 11,000 employees, big place. I was in Philadelphia for 7 years before I came here 3 years ago. I've been doing this for 10 years, but everything is bigger in Texas. Crazy. Now I'll introduce you to our Legacy Tower, and if you literally do walk 3 blocks, you'll see this. This is a massive high-level subspecialty tower where we have 4 floors of pediatric intensive care. We have 3 floors of cardiac pediatric intensive care, cardiac ORs, cath labs, recovery units, what else? MRI, specialty MRI, and a helicopter pad on the top. This just opened the first phase in May, and the cardiac ICU just moved there last week. What do we do there? We actually are #1 in the country for cardiac care and pediatrics, for surgery and cardiology. We take care of patients, little tiny patients who are born with bad hearts, their birth defects, their hearts are failing. Sometimes they need implanted devices, and sometimes they need to be even transplanted. We have 48 beds. The next largest cardiac ICU in the country is 26 beds. Like I said, bigger in Texas. Now I want to introduce you to our patients. 1 in 120 children are born with a heart defect. So in a conference this size, I think I heard 400. There's a handful of people actually attending this conference that were born with a birth defect of the heart. Even still, it's one of the leading causes of birth defect, infant death, and illness. Most of these babies need some kind of procedure before their first birthday. So this kind of environment with multiple life-giving machines, many monitors, beat-to-beat vital signs, hundreds of drug doses. Maybe I could compare it to what the military coined in the early 90s, maybe you've heard it, the VUCA environment. Very volatile, uncertain, complex, ambiguous. This is the environment where I work every day. And yes, I was made for it, and I love it. But how do we deal with a volatile environment? How do we deal with the complexities that actually affect a child's life? There I say, and I told you I wasn't a data scientist, and I don't know nonlinear Gaussian something or others, but I paid attention. The cacophony of data that comes to us, all coming really quickly, and this I'm kind of drawing out a neural network of some sort, right? Because this data is coming at me in a blink of an eye. I have to make those very data-driven decisions fast, or it's death. So dare I say, I'm not a data scientist, I actually am, in every second. And then we continually evaluate that care we give in order to take it to the very next level. The innovation that's going on in our cardiac center, like I said, implantable devices, synthetic hearts, heart transplants. These are going on because we're continually evaluating what we do. So my mission and my passion is actually the sedation and pain management of these children, because it's a very big part. This is a scary place. I just told you it could be compared to the battles in Afghanistan. It's not a place where you want your tiny child to be, or parents at the bedside. Sedation and pain management become very big part after the surgeons do their work. I was going to say damage, but after they do their work, we have to pick up the pieces, right, and keep these children safe to recover and fear less. The other thing about our intensive care, especially in the cardiac intensive care, it comes with toxicities. So I can recover a child with the most complex heart defect but there comes a price. And even in December of 2016, the FDA came out with a communication we thought was very bold, but they said that the anesthetics and the sedation drugs we use can damage babies' brains. And even in the Mayo, the Mayo, in May, they had a very large study that showed it's true. The anesthetics and the sedation drugs that we use to keep these kids safe in recovery can have a long-lasting effect. So our surgeons who are very good at doing incredible complex surgeries, we still need them to get to do second-grade math. We still need them to understand and be the future Rice data scientists, nonlinear, Gaussian, something or others. And we can do that as long as we're very careful what we do. So, like I said, this complex environment, very scary, lots of medications given in tiny little aliquots by syringe pumps, tons and hundreds, should I even say, intermittent medications given by nurses at the bedside. So we have questions about that. Okay, if these drugs are dangerous, what drugs are we using? How many doses are they getting? Are they exposed to some level of total dose? And then if you ask my colleagues, well, how is our sedation practice? If the FDA says, and the Mayo up there says that we have to be careful with what we're doing, we have accountability. Most of them will say, we're doing just fine. Well, are we doing just fine? How can we know? So I actually discovered that the data comes in lists and lists and lists. I could go to a baby's bedside and I'd have to scroll through lists, rows and rows of data to try to understand what the baby has seen or what might work in that blink decision I have to make. That's not acceptable. And so what do we need to do? We need to understand the work as it's done and not the work as it's imagined. And that's what you guys do every day. You look at data as it's done and not just imaginary. I know there's imaginary numbers. My son graduated in applied mathematics. That's probably my only credential to be speaking today. But truly, assessing our practice, making changes, measuring improvement, that all sounds great, right? Equipping our providers to make that decision with insight is most important. And knowledge is applied information. We could have called this data science conference, Knowledge is Applied Information. How do I bring that to the bedside? So I started on this journey. Literally, I'm describing this. We started with pen and paper. We started with literally paper and pencil to try to calculate what these children were seeing. It could take a couple hours just one child to see what they saw in one day. I don't have an army of medical students at my, to do that. I couldn't even buy enough coffee for them to do that. But then, we tried, and, as many of you know, Excel, okay, it's old-fashioned, but that's what we have, right? And, pivot tables, and there was a lot of fumbling. It really led to data paralysis. And a lot of people give up right here. It's true. And so, at the bedside, trying to understand for our patient, you cannot become paralyzed. You have to keep moving. And so, I was trying to gain insight from one of my biggest, publications, the Houston Chronicle, right? So truly, if Wells Fargo and Wall Street can count every little red cent that goes in and out of our accounts, if the Texas Rangers could know how many hot dogs and how many beers are sold at every stadium and where in the stadiums they're sold, if hot dogs and beer are as important, why wouldn't my babies and the doses and medications be just as important? So what tools are they using? And that's where I got with business informatics. Visual analytics that really came to the rescue here. So I literally, and with the small team, translated customers, items, profits to babies, doses, totals. And so with that, the same old thinking with the same old results and data paralysis really changed. And that's where I became all of a sudden a data scientist. And we decided a business informatics platform was very useful to count every single dose that the children have seen. So I went all the way back to 2011. And business informatics tools laugh at my data sets, 1 million rows, big deal, right? You guys are all laughing, I know, that's funny. But truly, this was never something we could see as a pattern. If this was your Wall Street financial report, you'd be thrilled. But if this is your child in the cardiac ICU, you wouldn't be so happy. This is our sedation use over the last years. This is our 2 drugs, fentanyl and midazolam, a pain medicine and an anxiolytic, or something that takes away anxiety, and the use over years. Like I said, This would be terrific if it was your financial report. But this is the exposure we're giving our patients in our cardiac ICU. Opioids and benzodiazepines, those very things that the FDA and the Mayo are showing are toxic to baby brains. And here we're having increased use per patient in our ICU. And the business informatics platform obviously can look at every single dose. I'm not limited by only a day or a month or a patient at the bedside. So then, this is just month over month, a typical financial report. It shows a lot of volatility, just like I told you that VUCA environment we're in. This is how month over month those medications are being used through the years. And so we have to get laser focused. Write down, how can we make changes? If this tool can then let me look at yearly and then look at monthly and then look at weekly, can it give me cumulative doses? Can it give me a change? Can I make a change with that? And so this is actually one of our most practice-changing visualizations, where this is an entire day. So if this is midnight, 1 a.m., 2 a.m., 3 a.m., across the bottom there to 10, 11 p.m., these are the number of doses given in that hour of the day. And this is all the doses, not limited, like I said, by age or anything. This is all the doses. You can see 3 spikes that are way out of standard deviation. And that's 4 a.m., 7 a.m., and 7 p.m. If anyone has ever been in the hospital, or especially in an ICU, 4 a.m. x-rays, 7 a.m. and 7 p.m. nursing handoff. So there's a rhythm. This is describing a rhythm of the unit, but all well and good, our patients are getting an incredible amount of dosages around those time periods. And that means it's probably more nurse-directed rather than patient-driven. And that right there was practice-changing for all of us. And that was created with data visualization. This isn't anything for you to really digest, but it's the protocols that we developed after we saw that. Our problem was probably nurse-driven sedation dosing rather than patient. And these protocols then point to the patient and how to treat the patient based on their clinical symptoms and needs. So what then happened? After we implemented this, an incredible amount of mandatory education web modules, which if you know what they are not happy. But they came out, and actually then, January of 2017, we had implementation, and you can see the downturn. It's very easy to see. And just counting medication doses, we were able to show that we are having an effect on our babies in the cardiac ICU. This, again, you'll recognize the fentanyl and midazolam line graphs, right, that are showing our weekly use by patient. And you can see fentanyl across the top. It's a cardiac ICU, surgical unit. The pain medicine maybe not as affected, but if you look, the benzodiazepines really significantly down. This was the toxic medication most talked about in those publications earlier on, told you about. So this is now people say, so maybe not as many doses, but are you still affecting the total exposure? This is fentanyl, an opioid, powerful, potent opioid. You'll read about it in the newspaper every day. It can lead to addiction in my patients and withdrawal syndrome. So if we can lower their exposure, we'll have less addiction and withdrawal syndrome. This is the line graph is what you've seen before. The bar graph is their exposure. You can see that we've actually made an effect on that. There's a spike there at Thanksgiving. Don't know. But this then would be benzodiazepines. That's that dramatic decrease, also in cumulative dosing. This one, let me see if I can get this little thing to work. This one, August 25th, 2017. Anybody? Harvey. We had nurses in the hospital for 5 or 6 days straight. We had doctors who never left. Our patients' families at the bedside never left. Maybe there was a little bit more benzodiazepine use for our patients. The crying baby you can only take for so long. It's very interesting. The variation by time of day, I showed you that before, right? So I told you that midnight, 1 a.m., 2 a.m., all the way across 10, 11, right? And this is the spikes, 4 a.m., 7 a.m., 7 p.m. Quarter 1, quarter 2. Maybe even a difference between day and night. Maybe it's straightening out just a little bit. Quarter 3 and quarter 4. This is how data science has affected the practice at the bedside. This has affected the child with cardiac disease in Texas Children's Hospital a few blocks away. That's what data science is. And you guys, do brilliant work, but you have to know that it's really affecting my patients. This is just another dramatic view of how the average daily exposure to our children has decreased, especially with benzodiazepines. We really are making a difference. Keep developing the software, people. So now what do we do next steps, right? So what do you say? Okay, great. Now you've changed the sedation practice. Is it really holding up? Is it staying around? You know, no protocol can ever be sustained without sustenance, so to speak. So this is actually just counting. I wanted to show you the dramatic increase of our census. So this is literally counting every patient that's come in as an encounter into the cardiac ICU just since July. The yellow arrow is the Legacy Tower opening. Our cardiac, we moved 65 patients to the Legacy Tower 12 days ago. So what do we do now with this census? I think that VUCA environment I described to you is actually only going to get worse, right? Now they're spread between 3 floors. So we really do need to have our finger on the pulse, the pun is intended, of exactly what's going on, right? So this is actually just a mock-up of an individual profile. This is one patient. These are all the drugs they're getting in that admission. This is actually more of a visualized kind of picture rather than those line and line and line and rows of data that I would never know about. This is actually what we're developing now, is more of a dashboard. I went to some fundamental classes to learn this business informatics. It was all with the ExxonMobil people. You know, and their executives can pull up a dashboard and know all of their vital statistics immediately. And you come to my ICU and a doctor can't tell you what the sedation medications were for the last hour. It's unacceptable. If ExxonMobil can do it, we can do it too. So now we're working on dashboarding. And so this is one particular patient, where they've been, what they've seen in the last week. This will actually give instantaneous insight, actionable insight to a physician at the bedside or a provider at the bedside. We can also build into this dashboarding best practice alerts, thresholds. This patient is seeing a whole lot. Hey, Dr. Achuff, you better pull back. What's going on? You're not going to be able to get that kid into Harvard. So truly, these analytics and insights are really making a difference in tomorrow's outcomes. So now I'm actually free to take any questions. I told you it was going to be light. Okay.
Hey, thank you. Great talk. And I think I have a comment and a question. Right? I wanted to highlight that what you described, even though it doesn't involve complicated statistical modeling or applying a classifier or anything like that, it is that's where I think the important part of an application of data science is in gathering the data and actually just looking at it, and there's a lot you can tell just by looking at it. And so I think that's something that we don't emphasize enough, that has the most practical impact. What I wanted to ask is, what do you think is the best way to engage data scientists? Is there a role for like a field deployed data scientist walking around with you as like a med student or a
Absolutely,
resident?
Yes. Because like I said, I can only take it so far. I'm 99% of the time at the bedside, and 1% of the time I'm down in my office trying to make patterns out of all this data. Mm-hmm. Thank Dr. Rusin over here. He's actually giving us data that's coming daily, on a daily basis now. So actually this morning I updated it until last night. I have every dose of medication given to our children in the bedside as of last night. Now, how do I make this usable dashboard? How do I bring this to a prototype? How do I iterate that? Do I have time? No. Do I have knowledge? I understand. I can show you what I want. So I honestly think a team of data scientists next to physicians, really, who understand the data and understand what those patterns mean and what they need to say, rather than data scientists over here developing something that's not actually useful to me at the bedside. Mm-hmm. So honestly, I think that partnership has to happen. And we're really attempting that. We're really trying to do it. But right now, it's one doctor kind of trying to figure it out. The business informatics tools are really easy. Mm-hmm. It's drag and drop. I mean, I'll get it. But taking this to the best practice alerts, this is the all what you guys talk about.
Thank you.
So one more quick question. Was the outcome better health outcomes for the patients, or was it to reduce sedation? And did that improve what metric to see if reduced sedation is actually, I guess that would be the long-term brain damage. So we won't know if this actually improves their brain damage impact.
Right away. So in all honesty, you're right. What you're saying is the early outcomes versus the late outcomes. What I didn't tell you is that all the early outcomes, in all honesty, are also being affected. So a lot of my colleagues around the country are finding that our biggest morbidities and mortalities happen when you're in the ICU longest. So the longer you stay with me in the ICU, the more likely you are to get sicker and die. Okay, that sounds horrible, but it's true. So the sooner that I can get children moving and progressing out of the ICU, the better, all around, for every morbidity that we can count, mechanical ventilation, infection, hospital acquired or otherwise, all together. So the sooner I can progress you, the better. The best way to progress a patient is to get them off these medications, awake and out of the ICU. So our early outcomes include reduced ICU length of stay, reduced mechanical ventilation, all those early outcomes that I didn't bring you. But honestly, truly, that we are making effect on that. And that way we are having early outcome effects as well as those late effects that we'll continually measure. Yeah. So what I glanced over because we didn't have time was those protocols are actually all based on validated scoring. So there's scoring of a child based on their stimulation to effect that's scored from -2 to +2. And so all that data is also collected. So the nurses have to score and then give a dose. So we want to keep that child at a certain score, we order it. I want to keep that child at a 0, which is calm and awake and happy. Or I want to keep them deeply sedated at -2. So then actually we do have validated scores, and it's actually another data. It's not, it's very subjective.
Like that, doesn't that affect the results?
Say again?
When you combine all ages in
Yeah,
these places, that
right.
affects the
Again, another thing I didn't bring here, but we actually can filter for all kinds of things. The unknown unknowns all come out. And we've actually had a lot of my colleagues write papers on all those unknown unknowns. Let's parse out this particular surgery. Let's parse out this particular age. Let's parse out this particular thing, and let's see how that sedation all settles out. So it's the database is now like a big sandbox that we all have been able to play in because it's able to be visualized so much easier than we ever had been able to do before. So thank you for pointing that out.